Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Good afternoon, everybody. Thank you so much for joining us for this Medscape Educational Symposium on Live MRI. I'm Victoria Cherniak, and it is my absolute pleasure to introduce my co-speakers, Dr. Bashir Taouli from Mount Sinai and Dr. Robert Marks from UCSD. And with this, we're going to start, and I'm going to call up to the podium Dr. Taouli, who will talk to us about use of hepatobiliary MRI for indeterminate nodules in cirrhosis.
Thank you, Dr. Cherniak. It's a pleasure to be here. So just some background about the use of LIRATs. A lot of us are using LIRATs in the practice, in the clinical practice, and we always come up with indeterminate liver lesions or observations. Typically, those are classified as LIRATs 3 or 4. These are typically intermediate probabilities of HCC development with variable risk. They do exhibit some characteristics, but not all characteristics of HCC on CT or MRI. If you go more in details, the difference between LR3 and LR4, LR3 can sometimes show arterial phase hyperenhancement without washout, typically on portovenous phase or delayed venous phase. Usually there's no diffusion restriction, and typically, there's isointensity on the hepatobiliary phase if you use a liver-specific agent like gadoxetate, and they're typically small. There are many differential diagnoses like perfusion changes, regenerative/dysplastic nodules, hemangiomas, early HCC also. The risk of malignancy overall is about 30%, give or take, 25 to 35%, so it's non-trivial. LR4, on the other hand, are more serious lesions with a risk of malignancy that's higher, around, I would say, 60%. So that's also risky, but just remember that about 40% of them are non-malignant. And those can be more suspicious than LR3. They may exhibit arterial phase hyperenhancement, portovenous or transitional phase washout, and hypointensity, but cannot be classified as LIRATs 5 because they don't have the whole spectrum of findings. So I'm going to show you a few cases exemplifying the findings. So this is a 71-year-old woman with metabolic-associated steatohepatitis cirrhosis who comes for HCC screening. We do a lot of MRI actually for HCC screening. I know it's against the guidelines, but this is what we do. The gadoxetate MRI showed at the bottom, showed a small lesion in the posterior aspect of segment 3 that has arterial phase hyperenhancement, but no clear portovenous washout, and isointensity on the transitional phase and HPP, which is shown on the right. And this was categorized as indeterminate liver lesions LR3. And the lesion was followed, of course, and was stable over 2 years. And if you look at the LIRATs table, this lesion had non-rim AFib. It was between 10 and 19 millimeters, but didn't have additional major features, so that is a LIRATs 3 and should be followed over time. So that case is not too complicated. Let's talk about this one. So this is a different case, another MASH cirrhosis patient, 61-year-old man with normal AFB. Same thing, comes for HCC screening. And then we see this tiny lesion in the back of right posterior lobe next to the kidney that has arterial phase hyperenhancement. There's no portovenous washout. However, there is hypointensity on the delayed hepatobiliary phase shown on the bottom left, and also some diffusion restriction, but no T2 hyperintensity. So this was not a hemangioma based on the findings because of the size. I'm going to show you the table. This had size less than 1 centimeter. It had non-rim AFib, but because of the HBP hypointensity and the diffusion restriction, we added one ancillary feature, and that lesion became a LIRADS 4 probable HCC, but it was small. And patient basically came back for follow-up. About 21 months later, you can see that lesion has significantly grown in size, and it has clear characteristics of HCC. About 2 years later, it was classified as LIRADS 5 and was treated with local regional therapy. So this is the third case I want to show. This patient has HCV cirrhosis treated for HCV. AFP was mildly elevated. The patient had also an MRI for HCC screening, and you can see there were multiple T1, mildly T1 hyperintense lesions, as you can see on T1 pre-contrast. These lesions did not really exhibit any arterial phase hyperenhancement as shown on the subtracted images on the top right. However, they were hypointense or showing washout on the venous phase, whether it's PVP or transitional phase, and were hypointense on the hepatobiliary phase. So when you look at the table here, this lesion is less than 2 centimeters, has no AFib, and could be classified as LIRADS 3. However, because of the hypointensity on the hepatobiliary phase, we classified this to be a LIRADS 4 or probable HCC, pretty much like the case number 2. This was a high-grade dysplastic nodule on histopath, and the lesion, the patient has been followed, and the lesion has been overall stable. So just to illustrate how complex sometimes the appearances can be, and how it's important to really approach this with a systematic way, discuss these cases eventually in tumor board, and have a clear path so that these patients don't get lost to follow-up. I just want to provide you, a possible solution. This was based on a review paper published actually this year by Singal, and I was actually part of this, where if you look at the LIRADS 3 lesion, it's really important to look at the size. If the size is small, you can really continue follow-up every 6 months. And if it's over equal 1 centimeter, you can do a early follow-up at 3 months from the initial index imaging, MRI or CT. If it's stable, you can come back to CT or MRI in 6 months. These patients with LIRADS 3, in theory, should not get ultrasound screening anymore. They should be really followed with cross-sectional imaging. And then if the lesion grows, becomes over equal 2 centimeter, you can consider a biopsy or even do a short-term follow-up. But biopsy should be really considered easily, if possible, in these patients. So for LIRADS 4, it's quite different because the risk is higher. If it's less than 1 centimeter, you can afford to follow these patients for 3 months. And if the lesion is stable for over 2 years, for approximately 2 years, you can downgrade to LR3, although the data is very small at this point, but that's pretty much what we do in our institution. And if the lesion grows, you can consider either a biopsy or an early follow-up. And if the lesion is larger than 1 centimeter, you have to be more aggressive and consider easily a biopsy. If it's over 2 cm, if it's 1 to 2, you can really consider early follow-up, and same thing, look at the threshold changes in size, and anything that grows over time is considered to be malignant and should be, in theory, be biopsied. So I just want to show just one slide on how at baseline, when you don't know what to predict in these cases, because what's interesting also is some of these cases that you see at baseline may already be early HCCs, but they just don't have the characteristics of typical HCC. So we're part of a consortium actually called the Transnational Liver Cancer Consortium that has 4 centers involved as part of an NCI grant. We looked initially as part of this consortium at a single center data from our center. We collected about almost 380 patients with LR3, LR4 lesions with MRI, with the excited MRI. Size was small overall, about 1.4 cm. And we've had malignant outcome in about 43% of these lesions. These patients had to be followed for at least 2 years. And we looked at modeling of the baseline characteristics of these lesions. So when you look at for instance, just the clinical model, the age, sex, and the blood test, meaning AFP by itself has a fair performance at predicting malignancy, about 0.73. This is in a test set, basically, so we did training, validation, and test set. If you look at the semantics model, meaning I call it 3 or 4, I provide also single semantic features like HBP hypointensity and, for example, diffusion restriction or AFI. That had also fair performance. However, when you look at the radiomics based on manual segmentation, the AUC was slightly better. But what's important is that when you combine all of the above, meaning the blood tests plus the clinical characteristics plus the radiomics model based on certain characteristics like SG boost, which is a way to model the data, we came up with an AUC of 0.87, which is really good at predicting malignancy. This has to be, of course, validated in a multi-center study in a larger data set. So just to summarize, LARAS 3 and LARAS 4 lesions in patients with liver disease, particularly patients with liver cirrhosis, can be difficult to diagnose or to approach. There is some inter-observer variability. I didn't mention this, but we are looking into inter-observer variability. Early data shows kind of poor to really fair variability for 3 and 4. These lesions, remember, have intermediate to high probability of HCC, so you really want to be very aggressive in following them and eventually do a biopsy very easily. And you can even consider sometimes treatment. We've had cases of treating these lesions eventually with a biopsy right before therapy. And with this, I'd like to thank you for listening.
Thank you, Dr. Taouli. And the next speaker up will be Dr. Robert Marks, who will talk to us about use of gadoxetate-enhanced MRI, abbreviated MRI for HCC and metastatic disease.
It's my pleasure today to talk to you about gadoxetic acid-enhanced abbreviated MRI. So current guidelines for screening for HCC from the AASLD recommends ultrasound and AFP every 6 months. And so here we have an ultrasound showing a big nodule in the right hepatic lobe, and we know that AFP can also add to the help screening for HCC. And if we look at LARAD's ultrasound surveillance, we have 3 categories for screening for HCC. 1 being negative, where you don't see anything. 2 being subthreshold, where you see a sub-centimeter nodule, and then positive, which is a 1 centimeter nodule. But I want you to focus now on the visualization scores, because it also, when you look at the LARAD's surveillance core, it also talks about the visualization score being if you have visualization A, there's no or minimal limitations, B, there's moderate limitations, or C, that there's severe limitations. So the key here is that not all ultrasounds of the liver are the same. We can see on the image on your left, in A, that's a good-looking liver. We don't see any distortion. We don't see any shadowing that's causing us not to see the liver. We can see pretty much everything on that, and if you scroll through this case, you'd probably see most of the liver, so there'd be no limitations. In B, we can see some shadowing. We don't see exactly the whole right hepatic lobe, or the lateral part of the hepatic lobe. This doesn't really, you feel like you can see most of the liver, but not, maybe some moderate limitations. This would be a visualization B. And on C, it's hard to see the liver. You have multiple areas of shadowing. You're not quite sure, what's liver and what's not liver. That would be an example of visualization C. And if you look at the surveillance guidelines and screening algorithm, this is important because if you have a person who has at risk for HCC, whether they have cirrhosis or chronic hepatitis B, they're supposed to get an ultrasound every 6 months. And so if they get an ultrasound every 6 months and it's negative, and they have a visualization score of A or B, they just go back to that screening population. If it's positive, then they go on to a diagnostic study with a diagnostic contrast-enhanced MRI or CT. But what if they have visualization C? What do you do then? If you're not seeing the liver very well, how are you supposed to mitigate this? Well, if you look at the guidelines from Ultrasound Surveillance Corps, you repeat the ultrasound in 3 months. And the truth is, a vast majority of these patients, when you do this, will go back to the visualization A or B and then go back to the screening population. And if they're positive, they'll go get on to the diagnostic study. But what if they have repeated visualization score Cs? Well, that's when the LIRAD surveillance talks about these alternative screening methods. So you may be asking yourself, what are these screening methods? Well, for one, you can just do liver MRI. You can do a full contrast enhanced liver MRI, but we know that's expensive. You can do CT, which has radiation, and so now you're exposing these patients to repeated radiation. So to combat these things, these abbreviated MRI protocols have been developed and studied over time. And so far, there have been 3 of these AMRIs, or abbreviated MRI protocols, studied. One's the hepatobiliary phase AMRI that is using gatoexetate. Then there's dynamic contrast enhanced AMRI, which is using an extracellular contrast agent. And finally, a non-contrast AMRI. I'm going to focus on the gatoexetic acid enhanced hepatobiliary phase AMRI. So what is a hepatobiliary phase AMRI? So if we look at the top, we have multiple different sequences here. And in this case, we have a mass in the right hepatic lobe that is mildly T2 bright. It has diffusion restriction. It has AFI. It has washout in capsule. It is dark on the translational phases and a defect on the hepatobiliary phase. But what if you took those purple the purple squared sequences, the T2 weighted image, the diffusion weighted image, and the hepatobiliary phase, and created an abbreviated MRI based on this? Would this work? So that's what a hepatobiliary phase AMRI is. It's basically the T2 weighted image, the diffusion weighted image, and the hepatobiliary phase image. So, and just to put this out there, the key on this is the reason that we thought of this in the first place was somebody can get injected with contrast or gatoexetate in the waiting room, wait 20 minutes, then get scanned. And so you don't have the problem of potential repeated sequences. If you have to repeat it, you can if there's motion, and you're not relying on dynamic contrast enhancement or hooking people up to a power injector. So here's a case. We see in this study, on your left-hand side, we have a hepatobiliary defect that is mildly T2 bright. So when I think about lesions on T2, we think of benign bright, things like cysts or hemangiomas, and then the scary bright or malignant bright. That's mildly bright. This is that case, where there's this mildly bright lesion, and it has diffusion restrictions. This would be a positive hepatobiliary phase AMRI. Why do we get the T2 again? It is to look to see if something is a cyst or hemangioma, basically. So as we look at on your left-hand side, we have things that are definitely benign. These are 2 cases that have hepatobiliary defects that you see with arrows, and you can see the corresponding fat-saturated T2 weighted image that you can see that these are bright, like bright as the CSF, bright as a gallbladder. This is benign bright. These are likely cysts or hemangiomas. Then the other categories, when we look at how we would score this, would be a subthreshold case. So here we have, when you look in the middle set of images, we have an 8 millimeter lesion in the left hepatic lobe that is mildly T2 bright. That's not a cyst or hemangioma. That's mildly T2 bright and has diffusion restriction. So this would be a positive but subthreshold case that you might follow again in 3 months or do a full dynamic contrast enhanced MRI. On your right-hand side, now we have a positive case that's more than 10 millimeters. So now we have a 16 millimeter lesion that has mild T2 hyperintensity. In fact, I would argue that this might have a targetoid appearance in this case and is markedly bright on DWI. So this actually might be something other than HCC, but either way, it is a positive case that would then go on to dynamic contrast enhanced imaging to get a final diagnosis. And the thought process is much like in BI-RADS in breast imaging. In breast imaging, you do have screeners, then you have diags. And so in this case, the thought is that you have these screening MRIs, these abbreviated MRIs, and then you have, if you're positive, then you go on to a diagnostic MRI. And the other part of this is that we know that sometimes abbreviated MRIs can find nodules that are occult on ultrasound. So on your left, you have an ultrasound there. Now, this was not seen prospectively, but in retrospect, you may be able to make out possibly a nodule there. Even knowing where it was, it's hard to see that nodule. But if we look, we have our hepatobiliary phase. We have an 11 millimeter nodule in the right hepatic lobe that is bright on diffusion. And you can see that it's not a cyst or hemangioma because it's almost a cult on T2-weighted imaging. So we know that it's not something benign. So this would be a positive abbreviated MRI screening case. Here's a couple of other cases. Here is a lesion in the left hepatic lobe that is mildly T2 bright. You can see the gallbladder in the same image. That would be benign bright. This is definitely not that. This is mildly T2 bright. That's a scary bright. Hepatobiliary phase defect and has diffusion signal. So this would be a positive abbreviated MRI. And one other case, on T2 on your left-hand side, you almost barely don't even see anything. Again, we have a hepatobiliary defect in the right hepatic lobe that on T2 we don't see. So that means it's definitely not a cyst or hemangioma, and it has some mild diffusion-weighted signal. This would be a positive abbreviated MRI with hepatobiliary phase imaging. What we know about the performance of the hepatobiliary phase AMRI is that, and this is all based on published retrospective studies on simulated abbreviated MRIs. So we know that it has a higher per lesion sensitivity and negative predictive value than ultrasound. And what this means is that if you have a liver with multiple lesions, that's on a per lesion level sensitivity. It provides a similar per lesion sensitivity and positive predictive value to reported values for a complete dynamic contrast enhanced MRI. Now, on a per patient basis, this means that if a person has multiple lesions, you see one. That's concerning. Can you detect that at least one? On a per patient basis, the per patient sensitivity and negative predictive value is higher than reported for ultrasound, and it provides a similar per patient sensitivity as a complete study with galactocetic acid. So, in thought process here, the AMRI protocols can be performed in approximately 5 to 10 minutes, which we do clinically at UCSD on these set of patients, and can be realized at a cost savings of about 30%. Through a grant that we had, and the subset of patients with MAFLD cirrhosis, we looked at a Markov model and compared strategies of ultrasound plus visualization score. So going through this algorithm of if a patient had a visualization C repeatedly and then got a hepatobiliary phase AMRI versus ultrasound alone for screening and then no surveillance. And the primary outcome was the ICER, which is the incremental cost-effective ratio, with a willingness to pay threshold of $100,000 per quality adjusted life year. Ultrasound plus visualization score, remember this includes the abbreviated MRI, was the most costly strategy in this model with an ICER of $59,000 relative to no surveillance. The ICER for ultrasound alone compared to this whole strategy of using visualization scores and abbreviated MRIs had an ICER of $80,000 to $822,000. And when you add AFP, which is actually currently recommended, to the ultrasound plus visualization score with the whole strategy of using abbreviated MRI, it remained cost effective with an ICER of $63,000 compared to no surveillance. This abstract's going to be presented tomorrow night. I'm not going to give you details here, but just to say that this was a translational study looking at the feasibility of even doing this prospectively. So patients were enrolled and got a same-day ultrasound and abbreviated MRI with a hepatobiliary phase at AMRI. This study never met power. COVID really affected the study. But in the subset that we had, the sensitivity was increased using hepatobiliary phase AMRI, and the positive predictive value was better. All other statistics were pretty much the same. So yeah, in the title, this is supposed to be metastatic disease, and so I am going to talk about metastatic disease too. And so what we know is that in a meta-analysis of diffusion-weighted imaging in galactocetic acid-enhanced MRI, not AMRI, for the detection of liver metastases, diffusion-weighted MRI is less sensitive than galactocetic acid-enhanced MRI for detecting liver metastases, but when you add the two together, diffusion-weighted imaging and galactocetic acid MRI is actually the best combination, and these results hold for colorectal metastases and also metastases that are less than 1 centimeter. And the question we asked for looking at pathologic responses to treatment, can galactocetic acid MRI predict pathologic complete response versus contrast-enhanced CT? These are complete MRIs. The sensitivity of the MRI is higher than CT, and the accuracy and negative predictive value are also significantly higher. Now, Personally, I really find using the hepatobiliary phase beneficial in looking at neuroendocrine mets. These are cases just from UCSD on patients who have metastatic neuroendocrine tumors. And if you look on your top left, we see a hepatobiliary defect, a small little subcentimeter hepatobiliary defect in the right hepatic lobe. On T2, it's almost occult. We didn't see anything. On contrast, arterial phase, portal venous phase, didn't see anything, but then it was bright on the diffusion-weighted image. And I think, for me, and I tell all our fellows and residents, when you're looking for neuroendocrine metastatic disease, to use galactosylic acid, because the hepatobiliary phase, I think, is very strongly helps in finding these metastases. So here's a sub-centimeter metastasis best seen on the hepatobiliary phase. Another patient, same thing. This is a neuroendocrine metastasis to the liver. We can see that there's a small sub-centimeter lesion in the right hepatic lobe. That is, you can barely see it, but you can on T2-weighted imaging. On post-contrast imaging, maybe there's some faint enhancement there. And on diffusion, you almost see nothing. But this, too, was a path-proven neuroendocrine met to the liver. To date, there's been 3 retrospective studies that have investigated hepatobiliary MRI, for colorectal cancer metastatic disease of the liver. These studies have shown that hepatobiliary phase AMRI performs as well as a complete MRI with galactosylic acid. These AMRI protocols have not been standardized, though, or become standard of care, really because of the higher cost and longer acquisition times compared to CT. But I personally think you can see these better with the MRI, but CT is quicker and cheaper. So more research is really needed in this realm. Here is a case from the literature on one of these papers. In fact, one of the authors is sitting right here. You can see there's a lesion in the right hepatic lobe that is mildly T2 bright. Your top left has a hepatobiliary defect, is bright on diffusion, and is dark on ADC. So this is a colorectal met to the liver. So in conclusion, hepatobiliary phase AMRI has been studied and is clinically used at UCSD for those patients who have repeated visualization scores on ultrasound. Hepatobiliary phase AMRI is one of the recommended studies by LIRAD's ultrasound surveillance for patients with poor visualization of the liver on the ultrasound. And I want to stress this. More studies are really needed to fully evaluate all these AMRI protocols. We use it clinically, but there hasn't really been proof that it is conclusive proof through multi-center studies. Hepatobiliary phase AMRI performs as well as full galactosylic acid enhanced MRI for colorectal metastatic disease, and also with that, further studies are needed. And I thank you.
Thank you, Dr. Marks. We're going to move on, and we just heard 2 amazing talks discussing the advantages of galaxetate for assessment, detection, and characterization of liver lesions in patients with cirrhosis. So what I'm going to do is extend this and discuss what added value the hepatobiliary phase has beyond just lesion detection and characterization. So we can start by looking at this patient. This is patient 1. You can see that there's a 14-millimeter lesion with arterial phase hyperenhancement, washout, diffusion restriction, T2 hyperintensity. If we apply our Lyards table, we're going to fall into LR5 category. Very straightforward little HCC. Patient 2, very similar appearance. We have a 19-millimeter lesion, AFI washout. Similarly, mildly T2 hyperintense and diffusion restriction. If we apply our Lyards table, we also will fall into LR5 definite HCC category. So are these 2 lesions equivalent? Yes, one is slightly bigger than another, but they kind of fall into the same range of sizes. So I want us to take a look at the appearance of these 2 lesions on hepatobiliary phase. Both of these lesions are hypoenhancing on hepatobiliary phase. Great. But if we kind of look in very carefully, and now we pay attention to the parenchyma surrounding the lesions, you can see that there's a difference between these 2 lesions. In patient number 1, the hepatobiliary phase, you can see the parenchyma is enhancing just like the rest of the parenchyma elsewhere, whereas in patient number 2, you can see a very subtle halo of decreased enhancement surrounding the lesion, and we call this perilesional hepatobiliary phase hypoenhancement. And it turns out that this is a very important feature. Both of these patients had resection. One has HCC, and another one had HCC with microvascular invasion. In 2 years, one patient has no recurrence, and the second person presented with recurrence in the same time frame. So again, perilesional hepatobiliary phase hypoenhancement, it turns out to be a very strong predictive marker. It is a predictor of MVI. This is a recent meta-analysis that looked at a host of different MR features which are validated for prediction, preoperative prediction of microvascular invasion. And notice that if we look at peritumoral hypointensity, it has the best, the highest diagnostic odds ratio. This is meta-analysis of multiple studies of all the available features that we have. It has the second best pooled specificity, second only to multifocality, and it actually has the highest pooled accuracy, even beating the multifocality for prediction of microvascular invasion. The perilesional hepatobiliary phase hypointensity also predicts outcomes, which are very important for us, right? So if we look at patients who had HCC and underwent RFA, and we look at overall survival, you can see that patients who have HCCs with perilesional hepatobiliary phase hypoenhancement actually do worse, and this change is statistically significant. And if we compare the 3-year survivals, you can see that HCCs with hepatobiliary phase, perilesional hepatobiliary phase hypointensity, their 3-year survival is substantially lower than those HCCs which do not have this feature. And the adjusted hazard ratio is 13. So that means that everything else being equal, presence of this one feature increases your chances of poor outcome 13 times, which is pretty impressive. What about intrahepatic recurrence post-resection? Very similar findings. We can see that the patients with HCCs which do have perilesional hepatobiliary phase hypoenhancement have higher and faster chances of intrahepatic recurrence as compared to those without this feature. And again, this difference is statistically significant. And if we compare the median recurrence-free survival between the two groups, almost 3 times longer recurrence-free survival of patients without this feature as compared to when this feature is present, and the adjusted hazard ratio is about 2.5 times. So again, 2.5 times higher chances of intrahepatic recurrence when this feature is present. What about patients who undergo transplant? Again, transplant is a curative option. What happens? And again, the recurrence-free survival is 4.5 times worse in patients with perilesional hepatobiliary phase hypoenhancement, even after transplant. So this is a very strong predictor of poorer outcomes when it's present. So again, this is again in patients who do have HCC. So is this all that we have? If a patient doesn't have HCC, does hepatobiliary phase have anything to offer? And it turns out that yes. So we have these 2 patients, both have fairly advanced cirrhosis, and just by looking at these 2 pictures, I'm going to pause for like 10 seconds or 5 seconds, and you think about who do you think, patient 1 or patient 2, is going to have better outcomes. And it turns out we can actually make that assessment because we can look at what's called functional liver imaging score, or FLIS, and it actually composed of 3 parts, and it's actually very easy to calculate. First, we're going to look at enhancement of liver as opposed to the kidney. We're going to assign a score of 0 if the liver parenchyma is less enhancing, score of 1 if it's iso-enhancing, and then score of 2 if parenchyma is hyper-enhancing to kidney. The next thing we're going to look as biliary excretion. We're going to assign score of 0 if there's no excretion. We're going to give score of 1 if excretion is only present in intrahepatic ducts, and score of 2 when the excretion happens to be into extrahepatic biliary tree. Finally, we're going to compare liver parenchyma against intrahepatic vascular pool. Score of 0 will be assigned when the parenchyma should be lower than the intravascular pool. When they're identical, then it's 1. And when the parenchyma is brighter than intravascular pool, then it's 2. So let's see this in practice. This is a patient with cirrhosis and Fleece score, the highest Fleece score of 6, 2 plus 2 plus 2. You can see the parenchyma enhances much brighter than the kidney. There's nice excretion into extrahepatic biliary tree, and you can see the parenchyma is much brighter than the intravascular pool. This is a maximal score of 6. Here's an example of score of 5. We have 1, 2, and 2. You can see that enhancement of the parenchyma is identical to the kidney. The other 2 parameters are preserved. Fleece of 4. Now we have still excretion is preserved into extrahepatic biliary tree, but the liver enhances like kidney and similar to the intravascular blood pool. Fleece of 3, now you can see that we have iso enhancement of parenchyma to kidney and blood vessels, and now we have a little bit of excretion into intrahepatic ducts, but nothing goes out into extrahepatic ducts. Now we get into really poor function, Fleece of 2, 1, 0, 1. Again, we have no biliary excretion. And Fleece of 1, now we have, you can see a little bit of parenchymal enhancement similar to blood pool. The other 2 factors are 0. And then this is a final Fleece of 0. And if I didn't know for sure that this is hepatobiliary phase, I would have never guessed it because it doesn't look anything like hepatobiliary phase because liver parenchyma is not accumulating any of the contrast agent. It's great, right? But why do we care? Well, first, interestingly, even though this is a qualitative, sort of qualitative-based score, the inter-reader agreement for the score is actually excellent. It's near perfect, which is very difficult to achieve for features that are based on qualitative assessment. So back to our patient. The patient number 1 has Fleece score of 6. The patient number 2 has Fleece score of 2. But how does it help us to predict how patient will do? Well, patient number 1 is okay, did not need to have a transplant about 3 years post these images, but in 17 months, the patient number 2 required liver transplant for liver failure. And it turns out that the Fleece is pretty good at predicting decompensation. So if we look at patients who have compensated cirrhosis and we separate groups into Fleece of 0 to 3 or Fleece 4 to 6, you can see that the patients with poor Fleece, with lower Fleece, are more likely to reach the first decompensation event. And hazard ratio is about 2.8, almost 3 times as likely. If we look at patients who have decompensation, and then look at their development of recurrent decompensation, you can see the same. If we separate the Fleece at 3, so 3 or less or 4 or more, you can see again that the patients with with lower Fleece are more likely to reach decompensation event anywhere between 2.1 to 2.8 times higher risk of decompensation. Transplant-free survival in patients who have compensated cirrhosis, you can see again, patients with Fleece scores of 0 to 3, that's our patient number 2, they have a much faster route to requiring the transplant as opposed to patients who have higher Fleece, and 7 times, almost 8 times higher risk of needing the transplant. And patients who have decompensated cirrhosis, similar separation of the curves, and about 5 times higher risk of needing the transplant with lower Fleece scores. Another use of fleece is prediction of post-hepatectomy liver failure. If we look at our fleece score, per each unit of increasing fleece, the risk of post-hepatectomy liver failure goes out about 2 times. So each unit you lose, you're twice as likely to develop post-hepatectomy liver failure. If we make a cutoff, in these papers, the cutoff was made of 5, so 5 or 6 versus 0 to 4. You can see the provided sensitivity, specificity, positive predictive value, a negative predictive value, and this is all just a pretty decent performance just on this very simple score that we can calculate within minutes without need for any advanced techniques, and we can actually predict which patient is going to do well post-resection. As a matter of fact, if we take the patient with a preserved fleece score of 5 or 6, and use the minor hepatectomy, so segmentectomy sort of as a reference, patients who have poor fleece and require similar extent of surgery still are 6 times as likely to undergo post-hepatectomy liver failure. And if the patients need even more extensive resection, they are 9 times as likely to undergo post-hepatectomy liver failure. So we do have quite a bit of prognostic information in this score. So what our key takeaway points is that hepatobiliary phase may offer our prognostic information beyond lesional appearance. We have to look for this perilesional hepatobiliary phase hyperintensity because it is a strong and independent predictor of microvascular invasion, and it is associated with poor outcomes following RFA resection and liver transplant. We don't yet have guidelines as to what we can do to change the management. The only thing that is known that if the patient is undergoing ablation, the area of perilesional hepatobiliary phase hyperintensity should be included in ablation to decrease risk of recurrence. And finally, fleece is very easy to calculate. It has very high, very impressive inter-reader agreement. It is an independent predictor of decompensation and need for transplant. And if patient is considered for resection, it is an independent predictor of post-hepatectomy liver failure. Well, we are running out of time. Thank you very much, and thank you for Medscape for organizing this session.